Today we are going to have a short presentation about the breast ductography, or also known as galactography, and its main indications. First, it's underused procedure. It's underappreciated. It's a very simple, helpful, easy procedure. It helps to define the cause of a unilateral, single pore, spontaneous nipple discharge. That single, the nipple has multiple pores. One of them is discharging. Why? You need galactography or ductography to know that. It's used also preoperatively to help guide accurate surgical intervention. That's very important thing. Pre-op, when the surgeon is planning to do some sort of surgery for the patient, you do galactography to help guide him where to go, up, down, right, left. Okay. Sometimes you inject the contrast and some extravasation happens. And if this happens, nothing to be worried about. Just reschedule the galactography after 1 or 2 weeks, and nothing will. It's okay, no problem. Don't be terrified. There's nothing wrong. Okay. You need, before you inject any bubbles from the syringe or the cannula, you need to remove them, because these bubbles will show up as a filling defect and might cause some confusion in the interruption. If you inject and contrast comes back, like a reflux, there's a possibility of a tumor that's obstructing the duct and causing the contrast to reflux back. Okay? When there is ductal ectasia, fibrocystic changes is the cause of the discharge, then you might use a conservative follow-up. You don't do the galactography. So, it has been called the diagnostic procedure of choice in the evaluation of nipple discharge. So, whenever you have a patient with nipple discharge, you need to do a galactography. There is a real indication for evaluation of this nipple discharge. Unfortunately, in our medical community, this is rarely done. We have a lot of patients with nipple discharge and galactography is not done. I don't know why, but this is the idea. They say it's just for intraductal papilloma, and this is totally wrong. There are preoperative planning is much more common indication than intraductal papilloma. Okay, so without ductography, the central duct extension may not result in the removal of the abnormal ductal tissue, may result in removal of only portion of the abnormal ductal system, causing the disease to be understaged. If you don't do galactography, the surgeon will not know how much of the duct is involved. He might remove part of the duct, leaving the rest of it. So you'll have disease recurrence. Okay? Or he might remove a whole wrong duct, leaving the original one in the patient, in the breast, and it's like doing nothing. Okay? So, how to do it? First, you need a patient with unilateral, single pore, spontaneous nipple discharge. Okay? If it is suspicious, like serous, bloody, colorless, or clear discharge, all of them are indications. Less suspicious if it is blood negative, yellow, green, blue, and even black discharge. It is less suspicious. Okay? So, first, you start by doing a gentle peri-areolar or nipple compression to see the discharge. يعني you compress the nipple حتى يصير discharge, so that you know which pore is the abnormal one. Okay? You know which pore to cannulate. First, when you can do some sort of palpation of the breast, part by part. One of the parts will cause the nipple discharge, and you have the trigger zone. You know this segment, this part of the breast is the abnormal, because when you pressed here, you got a discharge. So you have this trigger zone, okay? The part that you need to focus on. So it is defined as the focal area in or on the breast that when compressed reliably and reproducibly produce nipple discharge. Every time you press on this part, nipple discharge will occur. Okay? And the surgeon should know about this part, this area. And the breast tissue beneath the skin trigger point may be considered for inclusion in the surgical excision because they need to resect this part. Is there any contraindication for the galactography? If there is, first of all, like any radiological or contrast procedure, contrast allergy is an indication if it is significant contrast allergy. Just minor itching, it's not that, it's a relative contraindication. If the patient have a debilitating anxiety, mental disorder, you need a cooperative patient, a patient that knows what are we doing and is helping you do it correctly. Okay? If a patient is anxious, mentally unstable, don't do it. Okay? A history of prior nipple surgery that will completely disconnect the nipple pores from the underlying ducts. If she had a procedure, they just cut all the ducts from the nipple, whatever procedure, then you do a ductography for what? There is no ducts. It's not connected to the nipple. You will see nothing. It will not happen. Okay? Relative contraindication includes severe nipple retraction, moderate or severe reaction to ideated contrast material, patients with serious concomitant medical illness. These are relative. Okay? If the patient has nipple retraction, you can try, but you might succeed, you might not, because the nipple is retracted. It's difficult to grab. So, the standard ductography procedure, first, you need a good light, high light. Usually I use one of the headlamps, on the head, okay? Sterilize the area, and you pinpoint your pore of interest, the trigger zone. You do the palpation, or even sometimes you ask the patient which part, when you press it, she can show you the area. Okay? Put some sterilization on the nipple, and then prepare the contrast media in a syringe. It's just like 1 cc is enough. Discharge all the bubbles. Be sure that your contrast is bubble free because it might cause some problem to you. And then place the tip of there is a ductography cannula, but for me, I use just the plain yellow cannula. Just yellow cannula. You remove the metal stylet. You're left with the plastic sheath only. Okay? And this one you can, if you pinpoint the pore, you can try and gently insert it into the abnormal pore, into the abnormal duct. Okay? Just yellow cannula. You remove the metal. You have to remove the metal. And you use the plastic sheath. You just put it there. Okay? And then you slowly administer 0.2 to 0.3 mil of contrast material. If there is any pain or burning, you stop. 1 cc in the syringe is more than enough. You gently give like 0.2, 0.3, maybe 0.4 cc. Okay? And after that, you fix it in the skin. Okay? And then you do the mammography, medial and lateral parts, magnification views if you need it, other additional views, whatever you like. And after the diagnosis, you remove the cannula and you put some tape on it if it's needed. So it's so easy. You just sterilize the part, the nipple and you pinpoint your duct, the duct that is discharging. You use a very flexible plastic sheath of a cannula, or if you have a ductography cannula, even better. Okay? You empty the syringe from all air bubbles, gently insert the cannula in the pore, into the abnormal duct. You inject some contrast, you fix it on the skin, and then you go for doing a mammography and magnification views and whatever you need. Post procedure, you can also, after you remove the cannula, you can repeat the craniocaudal and mediolateral oblique views. For example, let's see these cases here. you can see this duct is extended inferiorly. This galactography, you can see the extension of the ductal system, which is directly subjacent to the nipple. And this is the same patient. Also, the craniocaudal view, you can see it's extending laterally. Oh, sorry. I'm sorry. Here you can see the ductal system extending inferiorly on the MLO view. On the craniocaudal view, you can see it extending laterally. Okay, so the ectatic ducts is extending inferiorly and laterally. This is the ectatic ductal system. Okay. While here you can see ectatic tortuous ducts also. This is called lobular blush. This is normal during ductography. Parts, the lobules get some contrast in it. It's called lobular blush. It's nothing to be worried about. It's just some of the normal findings that we see there. What do we have here? We have multiple filling defects. These are just air bubbles. So that's why you need to be careful not to diagnose that as multiple intraductal papillomas. How you can be sure? You just do some pressure, you repeat, and they will change position or change in size and number. Okay? Now, another example. This is also duct ectasia. You can see the dilated ductal system. Again, here you can see the dilated ductal system. Okay, and you can see here some fibrocystic changes also. The cyst, the contrast is layering within the cyst. Okay. Now, what do we have here? You can see some filling defects. Okay, outlined by, I don't know whether it's obvious or not. Filling defect outlined by the contrast medium. Also, the same thing here. You can see the contrast medium is coming like this, and there is a filling defect here. And that is an intraductal papilloma. This is what it would look like, okay? And you can see some papillomas here and there. They are calcified papillomas. Tamam? Okay. Again, you can see a filling defect here. That's a papilloma. Again, one here. And you can see some lobular blush. You can see the filling defect here. It's, again, papilloma, intraductal papilloma. You can see one here and one here. So there are different examples of filling defects. Of course, duct ectasia. What's going on? Okay. Multiple intraluminal filling defects, and you can see this here. This, like for example, a filling defect. This is called amputated duct. You can see circumferential filling defect. Okay. And surgery was done, histopathology revealed multiple papillomas. Okay? Now, what do we have here? Near the nipple, there is a large filling defect here. You can see it. It's filling defect within the duct, and you can see there is a nipple discharge. So ductogram was done. The standard central duct excision would have resulted in excision of the tissue within the cone. If no ductogram done, the surgeon would remove this part, okay, of the breast. While if you look carefully outside the would-be resected duct, there is also a filling defect here. Okay, so there was a filling defect here. If we did report that by ultrasound or mammogram or whatever, the surgeon would go and just remove this part, while ductogram showed another filling defect in the deep part, and this was a ductal carcinoma in situ, this thing here. So it was changed to total mastectomy. So because the patient presented with spontaneous nipple discharge, ductogram was indicated, and it changed the whole surgery. Again, every case with a spontaneous nipple discharge, unilateral, ductogram is indicated, especially if operative management is planned. Again, This patient presented with sanguineous single pore spontaneous nipple discharge during pregnancy, okay? And the ductogram showed filling defects within the ductal system here and there, okay? And you can see extensive casting pleomorphic calcifications in the breast tissue. And my laptop is not working good today, I don't know why. Anyway, so it was ductal carcinoma in situ, okay? So you can see there's filling defect within the duct with extensive pleomorphic calcifications. If it's indicated, mammogram, you do it in pregnancy. You just cover the apron shield on the belly of the patient. And by the way, mammogram is a very low dose procedure. Again, cover the abdomen of the patient with an apron shield. And if it is indicated, it has to be done. Okay? Now, what do we have here? Again, before the ductogram, you have this lesion with these calcifications, and after the procedure, you can see there are some filling defects here within the ductal system, and you can see this got opacified. This one, now it's opacified, indicating this is just a cystic fig, okay? So after surgery, it was a grade 2 invasive ductal carcinoma in situ associated with intraductal and intracystic abnormalities. Invasive ductal carcinoma was present at this region. Okay, so all of these are good indications for ductography. Again, this is another example of a carcinoma. You can see the filling defect here within the ductal system. And this was presented again with a spontaneous nipple discharge, okay? And before the ductogram, you can see there are pleomorphic scattered calcifications, suspicious features. Again, we have another example here. There is injection. You can see there is dilated ectatic duct, markedly dilated with this filling defect here. And it was a ductal invasive ductal carcinoma in the region of the when they injected, there was some extravasation of contrast. So we said when there is an retrograde or extravasation, this might be suspicious of a lesion obstructing the duct. So in my opinion, this was a good filling defect, and it was an invasive ductal carcinoma. So not to take much of your time, our case, the case that we did, was a 30-year-old female patient with multiple bilateral recurrent breast abscesses. She has multiple surgical procedures done previously with no benefit. It always recur. They resect part, they do some resection local, I don't know what, and it always recur. And her biopsy result was her breast ultrasound showed a BIRADS 3 in the right breast, and there were multiple collections. They remove it and it recurs. MRI of the breast was done not by us, she done it somewhere else. Anyway, there were bilateral medial axillary inflammatory lymph nodes and thick fluid containing ring enhancing abscesses, diffuse bilateral retroareolar mastitis. So it was basically recurrent mastitis with recurrent breast abscesses, bilateral. Okay, the histopathological report showed no malignant cells, and the pictures was going with mammary duct ectasia mastitis obliterans on the background of fibrocystic changes. So what do we do? First, the gram stain culture yielded no growth. There was numerous pus cells, numerous RBC and yeast cell, few. Okay, so we go to ductography to tell the surgeon where to resect, where is the disease. They were resecting blindly, just depending on the ultrasound. Okay, not sure what is going on, and we go for the Oh, come on. Okay. So we go for the part that is discharging. By the way, she had a skin fistula, that discharging pus. We leave that alone. Okay, we go from the nipple. Okay, and on the right side, you can see that the abnormal duct is going all the way deep to here. Okay, let me use the pointer. The abnormal duct goes all the way to here, and on the left side, it's not this part, is the deep part that is causing this big collection. And every time they do some intervention, they leave the deep part because they don't know that this deep part exists, and it recurs, and it makes a fistula to the skin. So our ductogram, the result was bilateral breast abscesses. On the right side, the contrast was collected in a sinus at the lower part of the inferior quadrants at 6 o'clock, and on the left side, contrast collected in the sinus at the lower part of the inferior quadrants. Also, we didn't see intraductal filling defects, but it told us, or we told the surgeon where to resect. Okay, and the surgery was done with bilateral quadrectomy, bilateral section of retroareolar duct system, and fistulectomy, because we said there were fistula to the skin with skin preservation, and there was collection of pus at the parts that we showed in our galactography or ductography. And the histopathological study, there were multiple dilated ductal spaces with inspissated secretions, with epitheliosis, chronic inflammatory cell infiltration, foamy epithelial histiocytes, multiple granulomas, and abscess formations. It was a complicated duct ectasia. Okay, and we had a follow-up of the patient, I think about 6 months later. She was perfectly well, no recurrence, and no new fistulas. So our procedure helped the patient. So in conclusion, ductography is a procedure that currently underused. We should use it more. We should recommend it more. It is simple. It is minimally invasive. It is very helpful to the patient, to us, and to the surgeon in deciding what's the pathology and what should be done, which part of the breast should be operated on or followed up or biopsized or whatever. And it helped us, the patient, and the surgeon. We should try to use it, or at least recommend it to our surgeons more. Thank you very much. See you next week, inshallah.